Hello, good afternoon, and welcome to this session for the Cambridge Festival on clinical leadership in law and ethics. And deliberately, I've put a watercolor picture of Cambridge here. This is King's College and the River Cam on a nice quiet day where everything is peaceful and tranquil. And obviously, this is how we would like things to be in clinical world, in the world of medicine, as a patient, as people. We like everything to be very calm and nothing too stressful happening. Something they also liked about this picture was the fact you've got that reflection in the mirror. And really, a lot of what we do in medicine and in clinical work involves reflection on how we're doing and how we can do and how we can do better. And on here, this is brought to you by the Professional and Continuing Education Institute of the University of Cambridge. And here we have our medicine and life sciences portfolio. So it's very much that link between the university and what people might think of the very old-fashioned Cambridge University idea with the fancy buildings and the punting and everything. And then that much newer 21st century style of the Cambridge Biomedical Campus. And here you can see Addenbrooke's Hospital, you can see Papworth, the Royal Papworth Hospital, AstraZeneca, and so many things expanding on the Cambridge Biomedical Campus. So it's that link between the academic in very much the real world. And of course, if you could zoom into any of the windows there on the picture in the biomedical campus, you would really see that, this is all full of patients, real life people, everybody with their individual lives, with their individual families and friends, who are all concerned and worried about health conditions. And every single person, every single family expects and should get the right level of care, the right level of ethical and legal treatment in there. With the Professional and Continuing Education Institute here at Cambridge, it is deliberately very much focused on those people who are in their own working environment. And I work with the medical and health science courses here. As you can see today, I am clinical. I thought it would make sense to deliver this to you from that very real world clinical setting so that you get the idea of that authenticity, that here's somebody who works clinically, but also works in academia and in quality improvement as well. I am one of the course directors on the postgraduate certificate in clinical research, education, and leadership. And it's really in that leadership role that I'll be talking to you today. And then that's part of the Masters in Clinical Medicine program here at Cambridge. I am also assistant professor of dental education here at Cambridge. To just give you a broader idea about me, my name is Thomas. Hello. I am a dentist and I work in special care dentistry. So I do a lot of my work under general anesthetic and sedation within a hospital setting. So I guess I have the background in dental practice, then moving into hospitals. So really can see what happens in hospitals and what happens in the healthcare system, as well as the academic side. The focus of the session today is looking at leadership in law and ethics relating to medical and clinical healthcare. And these are three very distinct but very linked ideas on there. We have that legal section in there. I mean, we all have the rules and the regulations, no matter what profession we're in, no matter what we're doing, whether it's crossing the road or driving a bus. We have those laws of the land that we must abide by, and those are there for a reason. Then we have those ethical issues, and often with ethics, what's discussed is the idea of an ethical dilemma. In ethics, we hardly ever talk about easy ethics stuff. It's always, oh, there's an ethical dilemma, there's a conundrum, there's a problem to be solved. And that's something we'll be looking at today. How do we approach ethical dilemmas in a clinical setting? And here we have then the leadership teams. So all of the clinical teams, medical, dentistry, nursing, chiropody, physiotherapy, will all have their own national and local leadership teams. But actually, everybody who is working within a clinical setting is within their own setting part of that leadership and part of that leadership framework. This is a condensed version of some sessions which I deliver on the leadership module of the postgraduate certificate in clinical leadership, education, and research. I've deliberately toned things down in terms of content for a public audience, but just to be aware, trigger warnings on here. There will be reference and mention to harm to patients and indeed harm to clinicians. Um, these will be using real examples and some examples perhaps from the local area and from the national media, which you may be aware of. But there will be nothing graphic shown. There'll be no graphic medical pictures. There'll be no graphic details of any of these real world harm incidents that have happened on there. But please, at any point, feel free to dip out if you feel that anything is triggering for you. We will have questions and answers at the end. And again, with that, just the disclaimer to say that on a session like this, certainly I'll be able to discuss leadership, law, and ethics and the general aspects. What I won't be able to do on a session like this would be answer any specific questions, perhaps about an individual case that you are going through or that is concerning of you. Certainly, I might be able to direct you and signpost you to some resources on there. So let's take a look at ethics to begin with. And with ethics, as I say, the wording with this is generally that there are these ethical dilemmas, these problems which, as clinicians and indeed as patients, we are faced with every day in our own practice. And with ethics, we talk about the four pillars of medical ethics. So these really are the four main points that we need to meet whenever we're thinking about anything ethical or any ethical dilemma. And the first is autonomy. Now, I know that in terms of technology and everything at the moment, particularly things like driverless cars, we talk about, the autonomy and the automotive and all these things. So it's something that's doing something on its own. And with autonomy, we talk about really the right of the patient to make their own decision, the right of the patient to make an unwise decision if that is what is their decision, and really supporting every patient and empowering them to be able to make the decisions that they need to make. So that is the first of the four pillars of medical ethics, autonomy. We'll come back to these with some real examples as we go through. Then there is the concept of beneficence. And with beneficence, bene at the start meaning good. And with this, beneficence really means always do good for the patient. If you are considering a test or a procedure, then will this be of benefit to the patient? Will it improve the patient's condition? Will it improve the patient's life? And with this, we'll come to more specific examples of this in a moment. And then the flip side of that, almost the yin to the yang of that, is the non-maleficence. So mal meaning bad. So maleficence would be a bad outcome, harm, something bad happening to the patient. And with this, for example, if there is a 1% risk of something bad happening, if there is a 99% risk of something bad happening, how do we communicate that with the patient? How do we allow and facilitate the patient to have that autonomy to make that decision based on these things? So non-maleficence, don't harm the patient. And then finally, the fourth pillar of medical ethics is justice. And with justice, we're talking about equality, equity, equal access to treatment, no discrimination in there. And again, we'll come to some examples of this in a moment. And when you think about those four pillars of medical ethics, then you can probably sum these up in that very old-fashioned philosophical idea of, Hippocrates, first, do no harm. We are here for the patients. We are here to help them. We're not here to have our own careers progressed. We are here to serve the patient. So the first thing is do no harm. And I think in ethics and leadership, there are certain core things that we always need to remember and core values that we need to come back to. And if, as every clinician and every leader in clinical setting remembers first do no harm, then that gets you on the right path from the start. A similar concept to that is the 6 dimensions of healthcare quality. So here we have that clinical leadership team there, and we're going to look at how the clinical leadership team always need to be very aware of these 6 dimensions of healthcare quality. This might be a new concept to you, but actually, again, thinking about law, ethics, and leadership, it really strikes me when I'm teaching that keeping these 6 things in mind for every patient, every time, is a very good moral compass to bring you back in to that leadership, ethics, and law right the way in every clinical decision. So the 6 dimensions of healthcare quality are safe, effective, patient-centered, timely, efficient, and equitable. And let's look at these individually. First of all, is what's being proposed safe? Is it safe for the patient? What are the risks? How do we know it is safe? Is it experimental? Does it have a bad track record? Not just does it have a bad track record, but what can I do as an individual clinician? What is within my level of training, skills, and competency and safety? And being honest about this with the patient, being honest about this with yourself and with your clinical team. So the very first thing, is it safe? And then is it effective? Now, effective is different to safe. Essentially, safe means, will it kill the patient? Yes, no. Effective means actually it might not kill the patient, but will it cure the symptoms? Will it alleviate the problem? So is what you're proposing to do effective, and not just effective, but the most effective thing for that particular patient? A particular procedure or test may be safe for the patient, but it may be that it's not effective or it's outdated. Then we have really, to me, what is one of the 2 big cornerstones of anything clinical, and this is patient-centered care. Again, who are we here for? We are here for the patients. I'm in a hospital today. If there were no patients in this hospital, if nobody needed any treatment, then none of the clinicians would need to be here. We are here for the patients. And this brings us back to that idea of autonomy at the start. We are helping to empower the patients to the decision that is correct for them. Is it timely? It may be that a procedure is effective and safe, but it's not very good if it's happening 6 months after the symptoms. It's not very good if an emergency resuscitation situation takes place 10 minutes after the patient has sadly passed away. Similarly, with pressures on the NHS and the health system, there will be 7 million of you out there at the moment on a waiting list, waiting for NHS hospital procedures. And how are we addressing that timeliness of care? Also, from a clinical point of view, is it efficient? Things like carbon footprint, cost, impact, waiting times, how efficient is what we're doing? We have that duty to make everything efficient. If we're getting you back for 20 separate tests before your procedure, but in fact, all of those 20 separate tests could have been carried out in the same appointment, perhaps by different teams collaborating together, that brings us back into that patient-centered care as well. And with the health service, we know that resources are not infinite. So therefore, we have the obligation not to waste money, not to waste time by doing things that are efficient, but also not taking shortcuts. So efficiency must never be at the mercy of safety or effectiveness. And then along with patient-centered care, something that really resonates with me always is equity of care. Are we discriminating against anybody? Are we giving somebody preferential treatment because of status, race, title, finances? Are we denying other people treatment, which is safe, effective, and efficient, because of protected characteristics, which we'll look at in a moment? So, is it equal for everybody? Is everybody getting the same chance to have that safe, effective, efficient, timely, patient centered care? So, on this, in terms of law and ethics, if you know nothing else about law and ethics as a patient or as a clinician, then absolutely think, is what's happening safe? Is it effective? Is it patient centered? Is it timely? Is it efficient? And is it equitable? And I think when you look at things that go wrong in the health service, then two of the big things which often get overlooked in all these things that go wrong, patient complaints, poor patient outcome, and sadly, what we would call non-recovery outcomes, patients who pass away, which could have been prevented, then often it's that patient-centered care. It's that equitable care, which are the two missing points in all of this. We're so busy looking at wait lists, we're so busy looking at numbers and statistics that forgetting about having everything patient-centered and equitable leads us into those legal difficulties and those ethical difficulties. There are other ways of phrasing this. We talk about no needless deaths, safety, no needless pain or suffering, effectiveness, no helplessness in those served or serving patient-centered care, no unwanted waiting, timeliness of care, no waste, efficiency, no one left out, equitable. So from a moral and ethical point of view, if you come to work as a clinician every day, and if you have this as your checklist, then you are on the right track. Let's have a look then in more detail at some of the pillars of medical ethics. Autonomy. I am a clinician doing a particular procedure. I know that this is the procedure that I've always done, and for me, it works. I know there are other procedures out there which may be more modern or may be different. It may be that I'm a surgeon, so therefore my idea is get my hands on and do something. It may be somebody else is a clinician who is working in the medical side. And their idea is, oh, there might be a pharmacologist or a pharmacist and say, actually, for us, rather than doing something hands-on and chopping something out, we would rather give a medicine or an intervention or a tablet or a therapy that way. The patient needs to be empowered to have the autonomy to be able to make that decision. You've got the surgeon with one opinion, you've got the medic with the other opinion, and we shouldn't, as surgeons or medics, be pushing patients into our own preferences and our own biases. We need to be able to give them the details to be able to make their own decisions on these things. Autonomy. Don't push your own preferences on the patient. Beneficence. And again, with this, why are we doing this? I know that in the healthcare service, there is a huge lack of resources. We've got to be able to think, is what we're doing of benefit to the patient? Is it of benefit to me? Is it a benefit to the health service? But primarily, those last two things don't really count. It's, is it of benefit to that particular patient at that particular time? Is it that we're having a research project where we need so many patients to have a particular procedure? That's not the patient's benefit, that's our benefit. So in ethics, always come back to what is of benefit to the patient. Non-maleficence. So with this, if there is a procedure which has a 1 to 2% chance of death, a 1 to 2% chance of harm, why are we doing this? Why are we proceeding with this? And with this, what you're doing is ensuring that whatever is happening, you're not harming that patient right the way through. So it's the flip side of the beneficence in there. And it's often something that gets overlooked, I think, in clinical aspects because we think, oh, we know what to do. And we forget about the idea of, well, what is the risk to the patient? Do they know the risks and have they been informed of the risks appropriately? Something that's always very interesting in this as well is the idea of justice. Justice links back to patient-centered care, to equity of care. And there are, in the UK, protected characteristics. There's a whole wonderful list of protected characteristics: gender, religion, belief, gender identity, orientation, age, nationality, disability, all of these things. And I'm not going to go through the whole list, but essentially, it is all these things. Are we discriminating against a patient because they happen to not communicate in the way that I communicate? They perhaps communicate through BSL or a different language. It's up to us as the clinicians to meet that need with them and to provide that justice for them in the patient-centered care and in the equity. And this brings us to consent. Consent is again a cornerstone both of ethics and of law. And basic definition of consent is to give permission for something to happen. Comes from the Latin consentiere, and con means together. So really, consent is never one-sided. Consent is between two people. It's a process that happens between two people. One person is not enough for consent. It needs to have more than one person for it to be consensual on there. Being very Cambridge, going back to Plato, 428 BC, Plato's definition was, I assume that your silence gives consent. So if a patient is in the surgery and if you take out a scalpel and start chopping off their arm, if they've not said no or they don't interrupt you, in terms of Plato's idea of consent, he would say, well, actually, they're giving consent because they haven't said no. In a Me Too world, and I guess a post-Me Too world at this stage, the idea of things being non-consensual, we now understand a lot better. Just because somebody does not say no does not mean they are saying yes. Somebody needs to make that active, informed decision to say yes, and we need to be aware of that. We can't just plow on and say, doctor knows best. And if you don't interrupt me, or if you don't tell me not to do this, I'm just going to plow on and do it on there. And consent lies within a much wider range of ethics, law, equality, diversity, all these things that we need to include the patient in patient-centered care all the time. And even with these, what I wanted to do was find a lovely Venn diagram where all these would overlap, but actually they're each so important individually. I think that pushing them all together makes very little sense. You've got to think of these individually, each patient, each time. I was talking to a philosopher here at Cambridge and asking them about the idea of consent. And then a theologist came along, and we were three of us talking about this. And really, among us, we decided that a very good way of briefly explaining consent is that if something is done to you, that's not consent. If it's done with you, that is consent. And so often, I think in the health service, especially when there are poor outcomes and there are complaints and there are scandals within the health service, we find that stuff has been done to patients, not done with them as part of the team and part of the decision-making process. Lots of different definitions legally in terms of consent. Implied consent, you come into the surgery, the fact that you're there, that you are giving your implied consent, that you are happy with everything going ahead. But then informed consent is really what's needed legally, that you are aware of all the benefits, all the risks, all the possibilities, all the timescales, and we'll have a look in a moment at what is important to you as well. Consent legally and ethically is process. It isn't simply, hello, Mr. Ramesh, we're going to take out one of your kidneys. This should make you better. Sign this consent form. Thank you. No, it's the process start to finish on there, and consent can be withdrawn at any point. Mr. Ramesh can say, well, actually, yesterday I thought this was the best thing for me to do. Today I've read up more. I'm having some wobbles. I've looked at the statistics. I've spoken to my family. and actually now I am withdrawing my consent. And that's something that we always need to respect. Looking at the legal aspects of this deliberately, I always say to our learners, our students, if there are ever more than 10 words on slide I have, then please don't read them. This is deliberately just a lot of legal framework that is in place in terms of the law around consent. And an old-fashioned, you may have heard of this, the old-fashioned idea of consent in the 1950s was the Bolam test. Well, this was really the doctor knows best. And this was what risks are there. And if the risk is seen as reasonable by a responsible body of medical opinion. So if most doctors think that the risk of doing that ingrown toenail operation, if they say the risk of losing your entire leg is actually a reasonable risk, then you don't have to tell the patient because that's a reasonable risk on there. That's doctor knows best, very paternalist on there. That then was reinforced by Sidaway in 1985, and that was a case where a patient had a surgical procedure on their neck. There was an estimated 1 to 2% chance of permanent nerve damage and paralysis. And unfortunately, in that case, that was one of the 1 to 2% of cases which did result in paralysis. The legal aspect of this said that actually, because that was only a 1 to 2% chance, and because a responsible body of medical opinion thought that risk was worth it, the patient did not actually have to know about that in advance. 2015, thankfully, things have been updated and moved on since then. Montgomery versus Lanarkshire, which is now the gold standard in this, is that actually the clinician has the responsibility to find out what is important to that particular patient about that particular procedure. And this was a case where a pregnant woman had various complications and they were proposing particular ways of delivering the baby. And that had, again, let's say a 1 to 2% chance of harm to the baby. In Sidaway and Bolam, it was said, well, actually, that's a small risk. Then if the responsible body of medical opinion says that's okay, we don't have to tell that expectant mother. The child did end up with permanent damage because of this delivery technique. And the Montgomery ruling was actually, no, what we need to do is find out what is specifically of interest and of worry and of concern to that particular patient about that particular procedure. Similarly with this, there was a case recently where an oral surgeon took out a wisdom tooth, very small risk of permanent damage to the nerve to the side of the tongue. And it's one of those things in inverted commas, oh, just sometimes it happens. That particular patient, it turned out that their job, that their hobbies, that their livelihood depended on speech and speaking. So to them, that was actually a huge risk. So even though there was a tiny risk, to them, it was a hugely important risk. So with Montgomery, we're talking about not how big the risk is, but how important that risk is to that particular patient. Now, when we talk about the paternalistic approach, then this brings us back to Thomas Carlyle and great man theory. So with this, it essentially says some people are just born great. The surgeon is able to say what they can do and what they need to do, and you must listen to that. And we think if we look on the left-hand side of the picture there, we have the great man. And then on the right-hand side of the picture, really, for every great man, it means they've got their foot in some other man's face. So with great man, it means actually somebody is always losing out. And great man theory definitely now is very much outdated. Surgeon knows best, and old white heterosexual Christian surgeon knows best feeds right into that idea of great man theory. All these characteristics which Thomas Carlyle said would have made that person great. God. Thankfully, in the 21st century, in 2026, now we think about things like style and behavior theory. in leadership. We've got that autocratic approach that surgeon knows best, doctors knows best, dentist knows best idea in there. On the other side of that, we got the democratic idea of, well, the whole team, the patient is involved in the leadership decisions right the way through on these. And then slightly to the other side of that, we got laissez-faire, which just means let it be. It's like the old song, let it be. But actually that means you're not intervening until something is going wrong. And sometimes we say that's too late. Let's look a little bit about the law in terms of consent. Who can give consent? Essentially, the starting point is to assume that every patient over the age of 16 has got the capacity to consent on there. There's that slight variation between 16 and 18, but over 18 is adult, 16 to 18 is considered a minor, but in terms of consent, a minor of 16 to 18 can give consent. Under 16, then it is whoever has parental responsibility, but it is if that particular under 16 can understand the benefits and the risks of a particular treatment. If they are mature enough to understand this, then in terms of Gillick competence, they can give consent, because we know that somebody who is 15 years and 364 days old, nothing magically happens overnight for that birthday when they hit 16 to suddenly make them able to weigh up the ideas of what's good and bad and right and wrong and possible in the world. And some people will be very mature at 14, some people will be very immature at 18. The Mental Capacity Act 2005 defines all this. So we're looking now at that legal aspect in terms of consent. With the Mental Capacity Act, again, the starting point is to assume that anybody over the age of 16 has consent. Now, if you have the time and the interest and that very geeky brain that I tend to have, you can read the Mental Capacity Act, 92 pages long. I wouldn't recommend going off and reading it unless you have a very, very specific reason to do that. So let's summarize that in a little bit. So essentially, an adult is considered over 18, a minor is 16 to 18, and in the Mental Capacity Act, do they have capacity or do they not have capacity to make up their own decisions? And there is a checklist that goes through on this. And it may seem like a very simple checklist, but it is very, very robust. Can that person understand? Can they comprehend the information that they're being given? Can they understand the options and the outcomes? Can they retain that information? So in 5 minutes' time, in a week's time, can you come back to them and they'll be able to remember any of this? Can they use that information as part of a decision-making process? So they may be able to remember all of the details, but not weigh it up in terms of the benefits and the risks for them. And finally, can they communicate that decision? And this is a standard NHS form which goes through that mental capacity assessment. So this will be for somebody who is over the age of 16 and details on there. And it goes through that checklist. Very important that we don't just meet somebody and think, well, you have a particular condition, you have a particular lifelong disability, therefore I'm making that decision straight away that you don't have capacity and you can't decide for yourself. No, we've got to go through this very, very specific process. Is there an impairment or a disturbance in the functioning of the person's mind or brain? Now, this can be permanent, this can be transient, this can be temporary. So this could be actually, is this person currently intoxicated by drugs or alcohol? It can be, does this person have an acquired brain injury? Is this somebody who has a severe adult learning disability? Yes, no, on there. And then explain how you decided this. Can they understand? Can they retain the information? Can they use that information as part of a decision-making process? Can they communicate that decision? It doesn't have to be verbal. It doesn't have to be in English. Do we need to consult with any other professions involved in that person's healthcare to make that decision? It may be the first time I've met that patient. And then having gone through all this, does that person have the mental capacity under the Mental Capacity Act to consent or refuse treatment. That's a really important point. The capacity is not just to consent for treatment, the capacity is also to refuse somebody ethically. They are entitled to make that decision, which you think is unwise. Then we go through the best interest checklist on that. So does the person have capacity? Is it likely capacity will return? If it is, let's wait. If we can't wait, why not? And then really important patient-centered care and autonomy in here. No matter what the level of capacity, has that person been encouraged at every level to participate in their decisions fully? So even though somebody might not have capacity to make up the decision, you still engage with them. There was that wonderful program on Radio 4, Does He Take Sugar? You're not going to bypass that person. You're not going to ask the carers, make eye contact with that patient, even if that patient doesn't have a physical voice to speak with. You're going to ask the patient all the time, not the carer. Always go through the patient, not the carer or the family. The carer of the family will then answer on the patient's behalf if needed, but you're not just simply doing this and then talking to somebody else, blocking somebody out. Not good ethics, not good law. And then at the end, you're signing all this off. Some legal stuff with this. Is there a lasting power of attorney? Is there a deputy appointed by the court on there? And if somebody doesn't have anybody else to speak for them, then an independent mental capacity assessment at IMCA can be involved as well. So there are those legal safeguards in here. Why are those legal safeguards in there? Essentially because previously stuff was done to patients without their consent. Again, I won't give graphic details. We're pre-watershed on this, and I know it's a general audience, but essentially people who were living with long-term health conditions or disabilities had procedures imposed upon them to make it easier for the carers, to make it easier for the medics, to make it easier for the doctors. And that is just, scandalous and should never have happened. So now all these safeguards are in place. And everything that happens must be in the best interests of that patient. And there's the legal terminology, a best interests decision. So the best interest decision goes back to those points, the ethical points, the 6 points of healthcare quality. You've got to hit all these things. And if you hit all those 6 points of healthcare quality, that is then in the patient's best interest. But also what you must do is take the least restrictive option. So if there's two options that will have a similar outcome, one involves having the patient stay in hospital for 6 months and have surgery and general anesthetic and repeated stuff. The other involves them staying in hospital for 3 days and having an IV drip and having some medicine at home to take for the next 6 months. Well, the least restrictive option is the one that must happen in terms of best interests. And here's an example of best interest paperwork. So you're going through, it's a two-step process. Do they have capacity? Yes, no. Now, if they don't have capacity, let's go through the best interests on there. And in this, the 4 pillars of medical ethics absolutely still apply to best interest decisions. Autonomy, although that patient may not have capacity to make that full decision, you still ask them. You still ask them for bits they can decide on. You get their input. Beneficence, you've got to make sure it's of benefit to the patient. You've got to make sure there's non-maleficence, that there's no harm to the patient. You've got to make sure that protected characteristics and justice are being in there. Just because you're making a best interest decision does not mean that you get to decide all these pillars of medical ethics can go by the wayside. And again, stop and think in any best interest decision, what about the dimensions of healthcare quality? Leadership, law, ethics, everything is intertwined on there. And in terms of medical leadership, the British Medical Association has got lots of resources to help medics, to help clinicians to make these decisions on there. An interesting thing that comes up, just taking a whole step away from that idea of seriousness of patient harm, recording. Can a patient record a consultation without letting the doctor, the dentist, the clinician know? Absolutely yes. The patient does not have to have the consent of the clinician to record this and even record it openly or record it secretly. And something we talk about in general anesthetic a lot is actually never say anything while the patient is asleep under general anesthetic that you would not say when they're awake, because almost assume that you're being recorded. Now, it never really happens, but assume you are. But yes, a patient can record you. The clinician, on the other hand, cannot record the patient consultation or video it without the express consent and the informed consent of the patient. So the patient does not need the consent of the clinician does need the consent of the patient. And that's for audio, for images, for visuals, for photographs, for everything. And in terms of any recording, then there's a primary purpose for the patient records, secondary purpose for teaching, tertiary purpose, advertising or non-clinical use. So let's have a look at leadership on here. This is the title of the report by the Right Reverend James Jones, the ex-Bishop of Liverpool, who we were very fortunate to have come engage and teach on our diploma in clinical medicine, our leadership module on accountability in leadership. We'll come back to why, pardon me, he is an important person in medical leadership as well in a moment. But the patronizing disposition of unaccountable power, I think, is a great term to use in terms of medicine again. Does the surgeon have all the power? Does the doctor have all the power on there? Because again, now this section might be a bit triggering, so just that warning there. We're going to talk about harm now, not so much to the patients, but to the staff and to the clinicians. We know, unfortunately, that racism within medical staff, racism against each other, is hugely difficult. We know from the nursing that racism remains a problem in the NHS, both within staff and from staff to patients. Institutional racism, that term that we'll remember from the Stephen Lawrence case. Faculty of Medical Leadership and Management, racism and good leadership are incompatible. And the NHS staff survey, this report on the Commission on Race, Ethics and Disparities, very interesting 3 lines at the top of this, which I've highlighted, that say, the NHS is a success story with, and I've got to take a breath before I say this, with significant overrepresentation of ethnic minorities in high status professional roles. Now, I know when most people in the NHS read that, they shuddered, because that in itself is an overtly racist statement. So thankfully, a lot of work has been done to unpick this. And again, lots of information out there about staff levels and COVID and racism and ethnic minorities. Another group we work with on the certificate in clinical leadership education and research on the leadership module, and then on the diploma, the BAME Healthcare Collaborative, because patient-centered care, equity in care, and the work that they do is hugely important. Something as apparently very simple that came up through COVID a lot was pulse oximeters, the little bit that's put on your finger to measure your pulse and your oxygen level. Who are they calibrated on? What type of skin are they calibrated on? Do they work to the same degree and the same level of effectiveness on people of different origins? It turns out they don't. Nasal cannulae, so the bits that give oxygen up your nose, they're all generally made for white European male noses. We know that the whole population is not white European male, and therefore those nasal cannulae were far less efficient in other people. Mary Beard here at Cambridge, the emeritus professor of classics, women and power. We know, and again, Professor Beard has been very kind to engage with our course and with our learners. That women and power, we know that women are at a disadvantage within the health service, both as patients and as staff. And then sadly, and I'm not going to dwell much on this, but sadly, there is a culture within certain aspects of healthcare of sexual violence and sexual harassment from senior people within the profession towards their juniors, using this as a power mechanism on there. And very interesting letter in the Times, which says that this snowflake generation of young doctors, largely female and selected in academic excellence, haven't done their homework. Essentially, they're saying that these young, bright female doctors should man up, as it were, if they want to get on in the medical profession. Hugely controversial that this letter was printed, but actually the reason it was printed was to provoke the outrage and to show that level of old white heterosexual male bias within the health profession. So actually the fact that this was published was very good in helping to move opinions onwards. Leadership, law, and ethics. I'm going to just do a little bus stop tour now of some things that have happened within the NHS in the UK, which should never have happened and which were breaches of law on so many levels. And then think, well, how, as leadership within the NHS, we can prevent these things happening again. Again, with these, I'm not going to give any major details, and deliberately I have pixelated the pictures of the perpetrators in there, and I'll try to avoid using any of their names, just not to give them that oxygen of publicity. Within healthcare, sadly, we know that tragic things happen. And in any hospital, there will be people who do not have the outcomes which they deserve or which they and their families would like to have. There are terminal conditions, there are untreatable conditions, sadly. On the other hand, there are completely preventable deaths. There are deaths which are caused by the selfishness, by the racism, by the attitudes and behaviors, by the laziness, and essentially by the evil of people working within the medical profession. Gosport War Memorial Hospital. This report was also chaired by the ex-Bishop of Liverpool, who did the Hillsborough report. Hundreds of patients, 450 people at a community hospital, had preventable deaths because of the actions of some medical staff who decided it was quicker and easier to keep them quiet by giving them lots of doses of opioids. A GP in the UK, possibly one of the largest serial killers ever within the UK, killing elderly patients and taking their money. You'll know who I mean. Locally here around Cambridge, at a local hospital, a now not doctor, but at the time a doctor who was abusing young, vulnerable patients within his care. The Winterbourne View Hospital, exposed by Panorama, a healthcare setting where vulnerable adults were being physically and emotionally abused. Alderhay, where a pathologist was essentially, again, apologies if this might sound triggering, essentially keeping bits of babies' bodies for no particular reason. Families were not getting the entire remains of their child back to bury. And then what I want to do is to focus on the good things. So this is the Ockenden report. This is Donna Ockenden, who's now leading a new report in the UK as well, looking at maternity services in Shrewsbury and Telford hospitals. And here we have Rhiannon Davies, who you can see standing there proudly with her pregnancy bump. And Rhiannon was one of those people who had the courage to stand up and shout and scream and say, no, this isn't right. This shouldn't be happening. And to stand up to the doctors and to the health profession. And then we have other cases here of clinicians who weren't sterilizing instruments, the largest recall for HIV and hepatitis testing in the history of the NHS. And then we again have these good people, Julie Bailey, who was awarded a CBE for her work in healthcare. Her mother died in Stafford Hospital. Again, a scandal there. Mid-staffs, lots of stuff I can signpost you to there in the media about that in the news. And the report on mid-staffs, essentially what happened was that lots of patients were dying because of lack of appropriate healthcare and just that institutional idea of doctor knows best, nurse knows best, and do not dare question us. The Francis report, 2013, and then this Freedom to Speak Up review, 2015, came from this. This is Sir Francis who did the report on there. And one of the big things that's come from this is freedom to speak up. So freedom to speak up is that legal framework within the NHS. If any member of staff sees anything that they are not comfortable with, they have the obligation to raise it and speak up. With that, it doesn't even have to be something going wrong. It's something that may be a bit worrying. It's something that could go wrong. And there's a framework within this, that legal framework. Every NHS trust will have a freedom to speak up guardian. That's a named role within the trust. And then there'll be people like me who are freedom to speak up champions, who are essentially the deputies out there. And I don't have it on today, that green freedom to speak up lanyard. So if anybody, not even in my own team, has any concerns about anything, they see somebody with the green lanyard and then they can say it. I won't go into the details. Some of you may recognize people on this, but sometimes, there's a freedom to speak up lanyard on there. This was an incident at a hospital within the local region. Don't have time to go into it, but where freedom to speak up didn't actually work. A surgeon in Brighton used a Swiss Army knife to cut open a patient. Couldn't find a scalpel, he said. Curious case. So all these things, we are all regulated by our professional bodies on there. We're all responsible to these. Curiously, and this is something that's come up recently, clinicians are all registered with professional bodies. Healthcare managers are not. A doctor, a dentist, a nurse, a chiropodist, a physiotherapist can be struck off. An NHS manager cannot be struck off. This is something that's probably going to change in the next while. And again, you may recognize this case, the Thirlwall inquiry into this. One of the big things in this was actually the NHS management. Were the management covering up for the sake of keeping a quiet life, for the sake of not having complaints, for the sake of not having a scandal? And were the clinical staff screaming and shouting about this for a long time and trying to raise it? Again, a champion of these sort of things, Anne Williams. Anne's son was one of the 97 people who were unlawfully killed in the Hillsborough disaster. And again, James Jones, the ex-Bishop of Liverpool, heavily involved in this and in healthcare as well. But it takes people to stand up and say and keep fighting and keep fighting. This is James Jones' report into that. So freedom to speak up within that legal framework is a really important point within leadership, ethics, and law in healthcare. So bringing it back then, we've got leadership, we've got law, we've got ethics. We've got the 4 pillars of medical ethics. We've got the idea of first, do no harm. We've got our 6 points of healthcare quality. And all the time, every day at work, as a clinician, think, am I hitting each of these 6 points for each patient every time? Because remember, we are seeing patients all day, every day. You as a patient, that is a big event. It's an important event. It may be the only time in your life that you ever come into a hospital. So you are you. You are one person. You're not just a number within the health system. This is the email address for any inquiries for professional and continuing education in Cambridge University. And what I'm going to do now is stop sharing and come back and see if we have any questions. If we have any questions on there. And again, as I say, let us know where you're joining from. Oh, sorry. Okay. That's not for me. Joining from Russia, thank you for an interesting talk. Topic always need to discuss. And that's the thing. It's an ongoing process. We can't just say, let's talk about this in a lecture for medical students and then tick that off and it's done. No, no, no. This is all day, every patient. How do you balance involving the patient navigating system pressures, lack of time? Lack of time is obviously a big thing within the NHS. And on there, what I'll always say is go back to those 6 dimensions of healthcare quality. And for each patient, each time, think how important that is. So how do you balance that? Now, that will be a very good way of getting back to the point of only do what only you can do. So as the surgeon, you're thinking, well, is it your place and your skills to engage with that patient of every step along the way? Or are there other people? Can the nursing team, can the anesthetic team, can the patient liaison team, can the PALS team engage with those patients to give them that information so that you are then freed up to do what only you can do? So actually, balancing is really difficult. And we talk a lot, particularly in terms of, after COVID, about burnout and pressure and people staying on many, many hours after work and getting all that stuff done, but at what cost to themselves, but keeping everything patient centered. And I would say, if nothing else from this, what you need to do is to think, is what I'm doing today for this particular person, for this particular patient, patient centered? Yes, no. If it is, you're hitting law, you're hitting ethics, you're hitting quality. If it's not, then that's when that little alarm bell needs to ring and that red flag comes up and you stop and you think, I've got to get this back to being patient centered. So I suppose in summary, it's a tough job. It's an emotionally challenging job, but it's also a tough job being a patient. It's a tough job being a spouse of a patient, a son, a daughter, a parent of a patient, a carer for a patient. You might only see that patient for 20 minutes. You might only see that patient for a particular course of treatment. That patient may be living with that condition their whole life. Their family, their carers may be dealing with them 24/7 or all the time through. So always stop and think, who's the most important person in the world? That patient at that time. And bringing it back into there, that is what I would say. Any more questions, feel free to leave them in the chat. I know this is also being recorded, so hello to anybody who is being recorded, who is watching this on recording. And apologies, I don't have a chance to answer questions from those of you who are in the recording. If you have any questions about the courses at Cambridge University, professional and continuing education, then please email the address that we had on there earlier. If not, are we going to get to the recording? As far as I know, the Cambridge Festival will then make the recordings available later on. Thank you for that. Thank you for that question. And thank you for your attention. It seems like the insurance companies, this is a question from the United States, can tell doctors what they can and cannot do. In the UK, you don't have to put up with anything like that, do you? Thank you, Martin in Texas. I will say in the UK, there's private healthcare and there is NHS healthcare. And yes, there are rules and regulations. There are what we call the National Institute for Clinical Effectiveness, NICE, which says what can and can't be done. There's that general, quite sad black humor joke within the medical profession that NICE actually stands for National Institute of Cost Effectiveness. So these are the people who approve treatments and essentially, is it clinically effective? Can the NHS fund it? But also, is it cost effective? So yes, unfortunately, we don't have an infinite budget. It's not as strict as the American insurance systems, but yes, we do have to work within that. But also, we have that legal and that ethical obligation to always push back against that and to fight for what is right for each of our patients. So many of us in these sort of clothes spend so much of our time fighting the corner for individual patients. And, this brings a huge amount of personal, professional satisfaction when you can turn a no into a yes and get something done. So thank you for engaging with this presentation on leadership in law and ethics in a clinical setting. Do reach out to the University Professional and Continuing Education Institute with any questions. And very nice to see you all keep safe in a very difficult and troubling time, in a very difficult and troubling world. Thank you so much. Goodbye.